Really honored to be here on this podium. Have been really touched by the previous presentations and the combination of technical engineering and patience, emotion really touched me. Congratulations for the organization, excellent balancing. Congratulations, really like it. Yes, as the introduction, we are a small company and we are located in Italy, and again, thanks to the organization, we put together some information for what is, well, a technique well known in most of the countries, but not yet known as we think should be, and this is Hipec. So we have something to share with you. Hopefully it will be an interesting series of information for all of the people involved as a perfusionist. We are a small company, as I said, located in Italy. We are about a couple of hours east from Milan and about 1 hour and 15 minutes from Venice. That they are certainly more interesting and well known than Mirandola. But nobody knows that maybe Mirandola is close by to something that could become familiar to you. In fact, in the range of about 40 miles, we do have interesting brands well known in the world. So Lamborghini, Maserati, again Ferrari or Bugatti or Ducati. So quite interesting to know that within really 40 miles there is a concentration of such kind of brands. And why I'm saying that? Because Mirandola is, again, not maybe so well known in the world, but it has a quite interesting history of more than 50 years for what concerns the biomedical district. So we do have more than, as I say, 55 years with very well recognized brands, as you can read by yourself, Baxter, Livanova, Medtronic, or again, Fresenius, and so on. So this kind of community is in the total of 25,000 people. About 6,000 of those are engaged in the medical field. We are basically developing, all of us, product for equipments and disposable, more than 100 companies and a total turnover of approximately 1 billion. So certainly a significant, well, district, if you like. Talking a bit about ORAND, which is one of these part of this community, is a private company established in 1999, specialized as a 360 degrees company in developing, manufacturing, and commercialization of both products, disposables, and equipments. Our headquarters, as I said, is located north part of Italy, in Medolla, and we do have a sales office here in US. The core business of this small company, as anticipated, is Hipec. What is about Hipec? I'm going to describe you in a minute. We do have some products. The focus is regional cancer therapies, and the principle of everything is that for the surgical oncologist, which is the key player in this area, the most important things for certain kind of tumor is remove as much as possible the tumor itself. What is not totally known is that in association with that, having not more than 60 minutes at the end of the surgery, you can apply what is the Hipec methodology. And there is one video here that has been spontaneously put together by University of Chicago that much better than me in not more than 15, 20 seconds will describe really why we believe it's so important, Hipec. So let me see if the video starts.
Hipec means hope for patients with abdominal cancer. Here's why. Hipec, hyperthermic or heated...
Sorry, there is, I know, some settings here that we are probably to fix it. Let me try now again. Sorry for that.
Hipec means hope for patients with abdominal cancer. Here's why. Hipec, Hyperthermic or heated intraperitoneal chemoperfusion is an aggressive targeted surgical technique for patients with a variety of abdominal cancers. Hipec helps with fewer side effects than traditional chemotherapy, deeper penetration of the medicine, and greater effectiveness in killing cancer cells than conventional chemotherapy. UChicago Medicine is one of the only hospitals to offer the treatment for both children and adults. How does Hipec work? First, surgeons remove the patient's tumors. Immediately following surgery, the patient's abdomen is treated with a heated chemotherapy bath. The chemotherapy is heated to cause blood vessels to expand and improve the medicine's penetration and effectiveness. The heated, concentrated dose of chemotherapy can directly target cancerous cells, destroying them before they can become future tumors. This also means that the chemo stays where it can help the most, rather than circulating throughout the body. After about 90 minutes, the surgeons wash out the chemo and close the incisions. We also offer minimally invasive Hipec to eligible patients. For some patients, Hipec will achieve a long-term cure for their abdominal cancers. In other cases, Hipec allows doctors to treat incurable cancers more like a chronic disease and less like a terminal illness. Hipec means hope for patients with abdominal cancer. Need more information about Hipec? Call 888-824-0200 or go to uchicagomedicine.org/Hipec. UChicago Medicine is here to help.
So the promise, I think, was maintained. Not more than 45 seconds or 1 minute just to describe what it's about. And that's why we believe that today, thanks to the organization, we can talk deeply about Hipec and the role that eventually the perfusion community in the world, now in US, could have a role, really a specific role in this kind of new but not so new, as I say, not so well-known application. This is our flag. We, as I said, we are present in these specific areas since 1999, so we have more than 18 years experience, more than 20,000 patients treated worldwide, and we are really focusing on R&D, which is the acronyms of ORAND. Hipec is the acronyms of hyperthermic intraperitoneal chemotherapy. And as we said, not absolutely secondary. What we are here about talking about is extending patient survival. So our focus was over the past 18 years, as I said, patient. We do have more than 280 centers we are dealing with in the world. So those are here just listed some of the centers by regions. You can see the major important centers in Italy, in France, in Germany, as I said, in Europe, but not necessarily only in Europe. So we have Russia, US, Latin America, India. So believe it or not, as I said, we are talking with daily with 280 centers specialized, and those centers, they are the most important and prestigious center in the area of surgical oncology, dealing with 35 countries, and as I said, more than 20,000 patients treated so far with our technology, and a bit more than 18 years of experience. So what we are trying, and what I prepare for you today, just trying to have a real an overview, but something that I'm sure are information that are not currently available to most of you. So try to have really objective data. For sure, Hipec is becoming a standard of care. We definitely have many tools to share with you. We have a diffuse experience done here in Europe and in Far East that certainly could be beneficial for the US. And if there is any, try to remove any doubts about the potential opportunity for these kind of things. So maybe you are aware or not, but Dr. Dietrich in 1990 was the very first surgeon in the world to infuse intraperitoneal cancer chemotherapy. And we are talking about 1990. Just in the year 2000, Professor Sugar Baker from Washington, D.C. developed the first standardization for CPB for CERS, sorry, the CO2 reduction in association with Hipec. And just recently, a few years ago, the guidelines has been put together. So this is really a kind of clear trend over the years, starting from something very minimal and embryonic up to nowadays. What I can tell you from our side, this is the same time frame, but split it from another perspective, from another cut. So in 1990, we definitely started to have promising clinical results, but they were just promising. In the year 2000, thanks to internet, the patient awareness increased dramatically. So for a patient with ovarian cancer, they were not happy to have CO2 reduction only, but Googling, checking, they understand, they learn that was an opportunity that was named CO2 reduction plus Hipec. And this kind of awareness is really where we are even today, try to generate as much as possible awareness. Luckily enough, the number of publications increased, and is part of the topic today about the publications, as well the number of surgical oncologists. Just for your information, when we started, and I'm so glad to see here a good number of participants, about 18 years ago, the group of surgeons worldwide, there were not more than 20. Last year in Washington, we had more than 1,000 physicians from all over the world that were really focusing on Hipec. Very, very interesting. And finally now, just a few months ago, we have a privilege to present clinical results that was never before available for the medical community. And this part of the presentation that you will see in a minute, not done by me, but one of the one of the surgeon that was in the committee of this kind of organization to have this kind of clinical trial done, coming from the Netherlands. What we can see from our side is certainly those are our experience. The number of centers that are using Performer over the years increase, as well as the number of patients treated per year. And again, the spontaneous request from well, countries that you never expect. Recently, Kazakhstan, or again, some area of India, they are calling spontaneously, asking for this kind of technology and training to grow and having this kind of methodology become standardized. This is the study that I was referring to. This is very, very fresh. Has been published on the New England Journal of Medicine, so nothing to say. It's probably one of the most, if not the most important magazine. It has been published at the beginning of March. And what to say here, for this multicentric study with a randomized trial, there were 123 patients with surgery only put together or against the same number, about 122, that utilize surgery and Hipec. As you can see by yourself, the recurrence-free survival moved from 10.7 to 14 months. The median overall survival, which is the most important really results, moved from 33 to 45 months. So this is, in the area of surgical oncology, I can tell you, phenomenal results. The 10 centers that achieved this kind of result, they could not believe that this was the outcome of. And we are talking about stage 3 of ovarian cancer that, as you may know, is really a large diffusion of the disease. So if this kind of Hipec with a few $1,000s and 90 minutes is working for such kind of really advanced stage, we believe that this could work even nicely for even less invasive disease like stage 1 or stage 2. As anticipated, we are a company, but we would like to really give this kind of opportunity to the community to learn more. And I asked Professor De Ing, that was one of the 10 centers. He's located in Eindhoven, in the Netherlands. So he prepared for you. Unfortunately, we invite him, we insist to have him with us, but he was not able to join us. So just last week, he prepared this kind of video. It's about 15 minutes that is really giving a kind of overview from his perspective on what is about Hipec and the results achieved. So I will try to start with the video. Hoping it's working, because we had some problem before with that, but let's see if it's working.
Well, good day. My name is Injas de Hing. I am an oncological surgeon at the Catharina Cancer Institute in the Netherlands. And it's a shame I can't be with you today to meet you in person, but I would like to discuss some of the future perspectives on the treatment of peritoneal surface malignancies with you today. As said, I'm from the Netherlands, which is a small country, only 200 by 300 kilometers, and only 17 million inhabitants. And you may know our country because we're quite famous for our windmills and even more together with our tulips. But hopefully after my lecture you'll be knowing the Netherlands a little bit more, because we have been quite active in the research and treatment of peritoneal surface malignancies. And what is peritoneal surface malignancies? Here you see an example of a tumor in the large intestine. As you can see from the left to the right, this kind of a tumors tend to grow through the intestinal wall, going from stage 0 to the left to stage 4 in the right. And once it has grown through the abdominal wall, it can spread to other organs, such as the peritoneal cavity. And in the right upper quadrant, you see an example of peritoneal metastasis. As you can see, these tumors, they grow on the surface of the peritoneum, and they look quite aggressive to me. The risk factors for developing peritoneal metastasis in colorectal cancer patients is a high T-stage or perforation of the tumor, a poor differentiation grade when lymph nodes are involved, and they are especially present in right-sided tumors and at patients at younger age. About 10% of patients with colorectal cancer develop peritoneal metastasis, and in high-risk categories, it's even 40% of patients. So the question is, how will the treatment of these peritoneal metastases evolve from now on? And I don't have a crystal ball to look into, but I do know what we did in the past. I do know what we do at the present time, so maybe we can look into the future by looking to all these facts. And in fact, there have been a lot of myths in our treatment area, and actually very little facts. One of the myths that even today most doctors believe that peritoneal surfaces malignancies are a very rare disease, and we have to address this issue by looking in our country. Again, we have 17 million inhabitants in our country, and these people are treated in only 89 hospitals. And every patient that is treated for cancer is put into the Dutch Cancer Registry. And with all these data, we can look for patients that suffer from peritoneal metastasis. And what we did find when we look into this big database is that basically all organs in the human body can cause peritoneal metastasis. The most prevalent being the colorectal cancers. About 10% of these patients develop peritoneal metastasis. Patients with gastric cancer have a 30% chance of developing peritoneal surface malignancies. And for instance, in pancreatic cancer, 20% of patients are eventually diagnosed with peritoneal metastasis as well. So if you look to the distribution of gastrointestinal tumors, you can see that the colorectal cancers make up for the majority of cases, but that stomach cancer, pancreas cancer are very prevalent as well. And if you put all the different causes of peritoneal metastasis together, you can see that if you rank them between the most common primary tumors in the Netherlands, that they rank actually very high. They rank the 5th place in the common primary malignancies. So my conclusion is that patients with peritoneal metastasis are a very relevant group of oncological patients in the Netherlands, and I do think in most countries around the world. So the myth is that even today most doctors believe that PSM is a rare disease, but in fact hundreds of thousands of patients are affected with disease worldwide. Well, during my residency, which was in the early 21st century, the myth was that peritoneal metastases were regarded as untreatable because they were resistant to systemic chemo and they were refractory to conventional surgery. And of course, it was time for a change. And if we call somebody to action for change, there's always an American who stands up and says, yes, we can. And in this case, I do think we owe it very much a lot to Paul Sugarbaker, who took the chance to make a change in this area, because he had a great idea, which was the concept that peritoneal metastasis should not longer be regarded as a systemic disease, but rather as a regional disease. And if you treat peritoneal metastasis by an intensive regional combination therapy, you can have actually good results. This regional combination therapy consists of two parts. The first one being cytoreductive surgery. Cytoreductive surgery means that as a surgeon you try to remove all the visible tumors from the peritoneal cavity. It has different steps, it's quite complicated, but you can see all these procedures, for instance, on the internet, on the websites I've shown you on the right lower quadrant. After the cytoreductive surgery is finished, you can proceed with the actual Hipec, which means that you put a high dosage of intraperitoneal chemotherapy, which is heated to 42 degrees and stays there for, in most protocols, for 30 or 90 minutes. And we call this combination therapy cytoreductive surgery followed by Hipec. And I do think that Hipec at this moment of time is the most common term to call the complete treatment. Well, it was a great idea, but is it a fact? Not really, because as we say, in God we trust, but all others must bring data. And that happened in 2003 with this publication in the Journal of Clinical Oncology. In this journal, the randomized controlled trial from the Netherlands was published that investigated the additional value of Hipec after conventional surgery. And this was the randomization scheme. We included 105 patients, and the standard treatment arm consisted of 51 patients, of whom 44 were treated. And in the experimental arm, 49 patients received an additional Hipec. And this is the most important figure from that publication, which showed that there was a survival benefit of almost 1 year for patients being treated with Hipec as compared to the standard treatment. So yes, I do think that this paper made the fact that Hipec was beneficial for the treatment of patients suffering from peritoneal metastasis from colorectal cancer. And already in 2005, it was put in the guidelines in the Netherlands to treat these patients with Hipec. So what happened next? This trial was conducted in 2003 in the Dutch Cancer Institute in Amsterdam, but over the years we have now 9 different centers in the Netherlands. And as you can see, there is a steady increase of the number of Hipec centers performing this treatment and of the number of patients that undergo this treatment, and it's going up rather steeply. In 2017, we analyzed all these results, and we wanted to analyze whether our Hipec procedures in fact did make a change for these patients. And again, we used the data of the Dutch Cancer Registry, and we divided the last 2 decades in 4 periods of 5 years, as you can see on this graph. And what we did see is that there has been a very rapid increase of patients being treated with systemic therapy, with palliative chemotherapy for the most of them. But since 2005, there's also been a steady increase in the number of patients receiving Hipec, as I showed you previously. And I do think that this is the most important finding, because what we did see is that in the earliest period, the median survival was only 7 months for the entire group. And it didn't really change until 2010, when Hipec and systemic therapy were becoming more prevalent in these patients. And then the median survival almost doubled to 14 months, which is of the entire group, which is, I do think, a spectacular finding if you consider that these are population-based data and not coming from a randomized controlled trial. So in 2016, in the Netherlands, about 28% of patients that could receive Hipec, in fact, did get it. And we were wondering, what is the practice around the world? So that's why we performed within the network of the Peritoneal Surface Oncology Group International, a survey on the internet, and we asked all the experts around the world how many Hipec centers there were at the moment performing Hipec. And these experts, they calculated that there should be around 430 centers worldwide at the moment. And the number of patients with colorectal cancer being treated with Hipec are about 3,800. So take it back to the Netherlands, about 16 to 17 million inhabitants in 9 Hipec centers, accounting for about 450 procedures each year. And we translate, and we also looked into the situation in China, which has, of course, many more inhabitants, but only 10 Hipec centers and only 250 procedures a year. So if the people in China would be treated according to Dutch guidelines, we calculated that there should be at least 776 Hipec centers and more than 38,000 patients each year. So there is a big difference in the actual situation and the situation that might be there if you treat these patients according to the guidelines. And in fact, we have to realize that in many countries around the world, about 0% of patients actually receive treatment. So how should we look at the situation? Should we look to the situation that our glass is half empty, because most patients with peritoneal metastasis around the world do not receive appropriate treatment? Or should we think that the glass is half full, which I do think, because Hipec is now implemented in an increasing amount of guidelines in an increasing amount of countries, and an increasing amount of patients around the world are getting adequate treatment. For instance, in the United States, very recently, Hipec was included in the colon cancer guidelines, which I do think is a very big milestone in the treatment of these patients. Back to our own institute, we started 10 years ago, 2007, and we have treated about 270 patients for synchronous colorectal cancer. Our survival rates at the moment are 38 months, which is already a lot better than at the time of the randomized controlled trial. But the question is, are we satisfied? And I don't think we should be, because this looks pretty simple, but there are a lot of questions yet to be answered, as you can see. Which is the ideal intraperitoneal chemotherapy? What about the dosage? What about the timing? What about the temperature? And so on. So there is clearly room for improvement on a lot of these issues. And just to show some of the current research that we are doing, it all, again, comes back to a statement made by Paul Sugarbaker, and he stated that it's what the surgeon doesn't see that eventually will kill the patient, because that is, in fact, what we cannot treat. And one of the things that we are trying at the moment is to make it visible. And we are doing that with fluorescent labeled anti-CEA antibody. These antibodies, they connect to the CEA marker on tumor cells, and by doing so, we can hopefully light them up by using a specific laser into the operating room. And this is what it looks like. This is a very tiny nodule in the small intestine, and I do think you all agree with me that you can easily miss this kind of nodules, and if you leave them there, they will regrow after the surgery and they will eventually kill the patient. But together with the CEA labeled antibody and together with the laser, you get this very, very clear vision of such a metastasis in the operating room, which I do think is a spectacular improvement of our ways to find these little tumors. We are also performing research in the animal lab. In fact, you can do cytoreductive surgery and Hipec in animals, and you can get a lot of questions answered. There are also a lot of clinical trials going on, especially in colorectal cancer. And one of them is a Dutch Colopec trial, who is trying to answer the question whether you can prevent colorectal peritoneal metastasis from happening in high-risk patients. And what we did do is we randomized high-risk patients between a standard arm, having primary resection only, and an experimental arm that included also adjuvant Hipec in these patients. And what we already do know, because the inclusion is already finished, is that it's safe to do so, and now we're waiting for the follow-up data to show if there is a beneficial effect of additional Hipec. But Hipec may be an effective method to prevent peritoneal metastasis in high-risk patients. So I've been mainly talking about colorectal cancer. A lot of work is going on in stomach cancer as well. And we have to realize, though, that there are a lot of patients that are suffering from another origin, and that are the female patients which suffer from ovarian cancer peritoneal metastasis. And these peritoneal metastases might be ideal for cytoreductive surgery and Hipec as well, because we do know that in gynecological tumors, cytoreductive surgery alone already improves survival. We do know that these tumors are very sensitive to chemotherapy, and we do know that ovarian cancers tend to remain in the peritoneal cavity for a long time before they metastasize to other organs. So that's why we performed the Dutch OVIPEC trial, which was a multi-center randomized controlled trial, including 245 patients with stage 3 ovarian cancer. It took quite a long time, about 10 years, in 8 hospitals to complete. And this is the randomization scheme. Again, 245 patients. They were randomized between standard treatment, being systemic chemotherapy, followed by debulking and systemic therapy, versus the experimental arm, which is basically the same, but Hipec was included into the treatment after debulking surgery. And these are the results, which are, I do think, very spectacular, because it did show that median survival with debulking alone resulted in a survival of 34 months. But when Hipec was added to the treatment, the median survival increased very significantly to 46 months. So by adding Hipec for 90 minutes to the operation, we could improve the prognosis of these patients by 1 year extra survival. And maybe you've heard of this trial already, because it was very recently published in the New England Journal of Medicine. Another good thing about this trial is that it did show that additional Hipec did not result in additional morbidity or complications, and that the quality of life in these patients was as good as in conventional treatment. So yes, for ovarian cancer, I do think that we made a very big step forwards. So coming back to the title of my talk, how will the treatment of peritoneal metastasis evolve from now on? First, again, we have to realize that it only started in 2003. If you look to the history of mankind, it is a very, very young science. But I do think that we had some very, very important steps forward over the last 14 years. And I hope that I've been able to cross out some myths in your minds and to come up with some facts that will help you to treat these patients. And these facts were that peritoneal metastasis affects about hundreds of thousands of patients each year, and it's not to be considered as a rare disease. That CRS and Hipec for peritoneal mets of colorectal cancer really can improve survival and is very safe in selected patients. We do see that CRS and Hipec will be increasingly introduced and implemented in guidelines worldwide. And we are really looking forward to the first results of preventive Hipec in high-risk patients. We did see the publication already early this year of the OVIPEC trial, which I do think will revolutionize the treatment of these patients. And we are also expecting very important trials this year concerning the peritoneal metastasis in gastric cancer. Many of this work will be presented in the next PSOGI meeting taking place in September, and we are all looking very much forward to that, because there we have a lot of experimental and clinical research coming to age, and we hope we can make new steps forward again. I do think it's clear to you that there is an urgent need for well-trained teams of medical specialists, and as you're all together today to share your ideas on this, I hope you are convinced that this is really the way to step forward. And I would like to thank you for your attention. A lot of this information I've been sharing with you can be found on these two websites, and well, if you are ever in the neighborhood of the Netherlands, be sure that you are very welcome to meet me and to discuss on these topics a little more. Maybe you would like to have some additional questions or training, and please be welcome and send an email to this address if you're interested. I hope you have a very interesting meeting today and hope to see you in the future. Thank you very much.
So as promised, I felt that was too important having this kind of presentation done by him. And I think he really gave us a lot of brilliant information and very promising information for such kind of still considered niche market. But we are talking about really 100,000 of patients that could benefit, and till today they are not yet benefiting of this kind of treatment. To the point that I just push myself, try to imagine some number. At the end of the day, this is a very welcome kind of information that I know is number, but is important to point it out. So how many patients they could benefit of Hipec? And what I just try to put together for you here, having a source of the GlobeCan, in 2018, the splitting between the different type of oncological most important disease from ovarian, colorectal, and gastric and pancreobiliary are listed here. About 2,600,000 patients, they do have this kind of disease. So if you just make a very rough calculation, the treatment could cost in the range of $1,500. It's giving mathematics automatically. We are talking about a very significant potential of about 4 billion. Not having yet, as anticipated by Professor Deing, clinical results in all the area, but only in ovarian and in colorectal, but miss the gastric and the rest. We just remove from the calculation and try to move away the potential given by this. So even in this case, we are more than 2 billion as potential number of, consequently number of patients treated. So of these 2 billion, we just cut half and half again to get to the point of half a billion. So just to tell you the magnitude of what we are facing. So how we see the market trend, why we believe that the Hipec is becoming a standard of care, and what about the competition? Is there any rumor on what's going on? And again, the number of centers involved in Hipec, and again, price trend or level of conflict. So this is our view of what's going to happen. So certainly the expected market is there. Luckily, there will be thousands of patients that they could be treated that they were not just yesterday, as well as the standard of care is becoming for sure with Hipec. We are expecting that the number of people and competitors will increase, which is a good news. So we will not just few small private companies looking at that picture, but maybe many other will be part of the game. And it's for sure, it has been already well described by Professor Deing as well. So the number of centers involved with Hipec will definitely increase. And we are expecting that the price will stay stable. And, the level of conflict, which is certainly increasing, could be a good news or not a good news. But this is the view we have. So since the beginning, ORAND, and I'm closing, tried to really focus on few things. Education, you can imagine for a small private company, 18 years trying to expand and teach, educate people alone against the giant of pharmaceutical companies. So it was not an easy task. And that's why we are particularly proud today to communicate to you that now we have clinical evidences. We do have this kind of web page where all the patients, they could download and visiting and having the most updated publication by pathology. As mentioned, the first clinical randomized result trial was ovarian. This has been already discussed and presented. Again, New England Journal of Medicine. This is really a kind of milestone for this kind of area. But are expecting other results on colorectal in the coming years and in gastric. So this could be just benefit the expansion of Hipec. We are present in many international workshops worldwide. We are collaborating with the most important European community. This is, for instance, the Christie Hospital. They are witness, and they treat more than 45,000 patients, oncological patients per year. And they are using systematically our machines. Again, the Charité Hospital in Berlin, another masterpiece in Europe, and they are organizing at least 3 times per year workshops to, again, educate and promote Hipec. Our webpage is also dedicated to patients, so patients they could visit and having an insight where they could visit or be visited. There is a multimedia session where everyone can look at what is about the methodology. And as I said, we are particularly proud of being probably one of the first small independent company having such kind of academy project. So we are helping physicians from all over the world to transit and to migrate from one part of the world to the next one just to teach, and having vice versa new teams visiting them to learn the surgical technique and the Hipec situation. This is just an example. In a bit less than 1 year, we have more than 30 different events where we are present, so really a big interest. Few things about the specific and the technical matters. So the product that we are proposing, and you can visit at our booths, is compatible for both Hipec and isolated limb perfusion. It has 2 pumps, so this is very important to correct the patient's balance and for the best stability of the patient, of the temperature of the patient. It has a dry heater, so there is no risk of contamination. We don't have any water involved, but is electrical plated heater. We have a very nice automatic management, so the user, the perfusionist, just needs to push a couple of buttons and the machine does the rest. We do have a very accurate monitoring. Having 8 different temperature is vital. Having a precise temperature within the abdomen, 1 degree in difference between one position to the next one could impact in having 10% less the capability of the efficacy of the drug to penetrate the tumor. And well, ease of use, and finally traceability, having an integrated printer. So this is just technical matters. And the overall kit is disposable, obviously. It's called Hang and Go because it takes less than 5 minutes to be assetted. We have already the first generation done 20 years ago. The second one has 10 years. So we are ready for the third generation that will probably be launched in the coming 2019. So with this I conclude, and I hope that I was able to give you some information about Hipec. Thank you. If there is any question, more than welcome.
Yes, Dr. Menghini, thank you. Mr. Menghini, Doctor? Mr.?
Mr.
Mr., okay, thank you.
Thank you.
Very nice presentation. I played with this around 15, 16 years ago or so with a modified system. We actually used vacuum assist to help with higher flows, and now you have mechanisms and servo feedback with double rollers and all this kind of thing. My question is, first of all, this is still considered a palliative procedure when it's intraperitoneal. Is that true, rather than a full recovery? In other words, extending life beyond what they might have and taking the pain away at this point?
Yes, it is still considered as a palliative, but luckily enough, in our experience, and Professor Deing explained it, the survival is really moving from 30 to 48 months. And luckily enough, in a number of cases, the patient is completely out of the problem, so is completely cured.
That's great. And what is the maximum temperature that your machine will heat the solution to?
Yeah, thank you for asking. This is a really crucial question. And you mentioned we are not here to having invented the hot water, but typically most of the centers, the standard up to a few years ago was an handmade machine with some tricky situation to adjust the maximum level of temperature in the heating system of the cardiac surgery. The maximum temperature that this system is generating is 43.5 degrees. So we are sending fluids up to 43.5 degrees into the abdomen. We have 8 channels to check if the homogeneity of the solution is around all the different districts, and at that time we can inject the drug. So there are several protocols. The suggested temperatures worldwide accepted is about between 42 42.5 and 43. So that's why we can exceed a bit that kind of temperature, up to 42.5.
I think it's terrific. You know, we're not talking about blood here for hemolysis, but then we have to worry about apoptosis, of course. But I know in the literature, some of the literature has gone up to 46 to 48 degrees, and has that, you know, I realize your machine won't do that, but I mean, has there been problems with that, or has that been actually enhanced take-up of the drug at that higher temperature with the increased metabolism of the cells?
No, you're right. Unfortunately, as said, the variables studies over the years move from 41 to 48, 46. Has been now worldwide standardized that the best ideal temperature is between 42.5 and 43.
Thank you.
Thank you.
I've got a couple questions over here that I'll try to summarize. With respect to the hang and go system, what are the, like, if you wanted to get into Hipec, we've got a couple questions revolving around training. What kind of training would a perfusionist need, and what would be the duration of some of these procedures? How much time that they would, you know, take if a perfusionist is going to be asked to do these procedures in their hospital setting?
Well, thanks for who is watching from remote. We are equipped for guaranteeing training to all the perfusionists that needs that. In our experience, 2 full days training is enough to have a complete information that allows the perfusionist to do the job by himself. And we are structured for that. It's critical. It's part of our really guidelines, because education is really part also of this kind of process. Educate the center through the perfusionist and be sure that he's doing the things in the proper way. The duration, if I catch the question, how much time is needed for the perfusionist to be involved, is the duration of the treatment. So if the surgery that could be very length, up to 5-10 hours, the Hipec treatment itself is not longer than 60 to 90 minutes.
Good morning. Thank you for your presentation. I actually had the pleasure of working with Dr. Sugarbaker as he pioneered this work up in DC. His enthusiasm was amazing. He actually would help us bring the heart-lung machine to the OR. He would help us wipe it down at the end of the case. If every surgeon brought that sort of go-get-em attitude, cardiac surgery would be a pleasure to be in. I'm curious, the Hipec side of things versus the isolated limb perfusion side of things. Your machine is capable of doing isolated limb. You have an oxygenator along with your...
Yes, thank you.
Just because Hipec doesn't necessarily require a perfusionist. One of the things Dr. Sugarbaker would rub my shoulders and say, don't worry about all that air. It won't matter. It won't matter. But isolated limb, because it's actually intravascular, is a different animal.
Thank you. Absolutely good taken question. And I can guarantee you, we just met recently Professor Sugarbaker, and his enthusiasm didn't move. He's still like this as it was probably at the time that you are mentioning. Yes, the system we are offering is capable for both, for Hipec and for isolated limb perfusion. The machine has a specific double software that the user can select in one Hipec mode, or the same device with a dedicated software switch to isolated limb perfusion. You are totally right. If the Hipec could be managed by also a not perfusionist type of background, the isolated limb perfusion must be managed by a perfusionist. And we not only recommend, we pretend that the machine used in the ILP modality must be used by a professional perfusionist. But that's why I was so pleased, and again, thank you, the organization and the introduction. As you understand the link between the world of cardiac surgery and this kind of world is very, very thin, very, very linked. I can tell you that the number of isolated limb perfusion treatment is still a very minimal, but is existing. And we have centers specialized in Europe, in the Netherlands or in France, that are using isolated limb perfusion routinely, managed by perfusionists.
Is your machine the only device that's on the market currently that doesn't have a water bath for, you know, the heating component?
Well, we luckily avoid the water bath by principle. As far as I know, there is another company that has a system similar to this one, but this machine is not capable for isolated limb perfusion and is not, let's say, complete as ours in terms of number of temperature probe and automatic way to manage the perfusion. Thank you again.